So if we can get it away from this area, then we certainly can try to leave a little bit of a pouch there, okay?
But
You know,
you can't save most of that stomach, that you know, it's not touching, like on the bottom half of it, you can't leave that.
well, part of the problem is that we wanna take all of those lymph nodes. Those lymph nodes, are around a bunch of vessels, and so we end up wanting to remove a lot of the vessels around the stomach for a good cancer operation. So I don't want to skimp on your cancer operation to save you more stomach.
Sure.
So I definitely wanna have a good, a negative margin on the mucosa. If I can leave you a little bit of a pouch, we will. But I'm gonna be taking all the blood vessels, all of the lymph nodes around the stomach, and then behind the stomach, even around the pancreas. The spleen will come out. We talked about that doesn't really change things too much for you, and we can get vaccinations for you today. And then that adrenal gland, you have two of them. Taking one out doesn't really change your steroids or adrenaline that your adrenal gland produces.
Okay.
So I don't think you'll be low on that or need any medications to supplement that.
Okay.
When we put things back together, and the esophagus will come down. If we can leave a pouch on the stomach, we will. And what we do is we bring up the loop of your small intestine. So we divide the small intestine down here and we bring that up there. And then we sew this area together and we sew this area together,
Okay.
two areas. So then your food kind of comes down. This acts as kind of your new stomach. It expands over time, dilates, starts to act as a reservoir. All of your bile and your pancreas juice comes down this way, and then absorption happens down here.
Okay.
Okay? It's called a roux and Y. Okay? Just a French word meaning that Y formation if you look at it. It's not unlike a gastric bypass type operation as far as the amount of reservoir. This is much shorter than gastric bypass, so you don't have as much weight. You're not going to lose as much weight because there's going to be more absorption.
Okay.
Because this is only going to be probably about 20 centimeters or about a foot in length. We talked about we would end up putting a feeding tube down here. Temporary. Generally, we start the tube feeds by the third day after the operation, and it's just liquid feeds that kind of go into your system, helps you with your nutrition while you're recovering. Somewhere between day 5 and day 7, we would have you do a swallow, meaning you would drink some contrast, we watch it go down, and make sure that everything is healed together well. And then we start letting you have some liquids to drink. Start with clear liquids, and then milkshakes, and then eventually soft food.
All during hospitalization.
All while you're here.
Okay.
Home health, how much do they assist with? We'll want that type of information, how frequently they come in, what they help him with, and then he had questions about his, activities of daily living.
I would
impacts.
say, you'll probably be back to feeling where you are now, certainly by 6 to 8 weeks. Okay.
All right.
Main limitation is no lifting more than 15, 20 pounds, but walking around, we're gonna have you do here, we're gonna be doing stairs. You'll at least want probably an additional 2 weeks once you go home. I would have planned for around, as far as off from work.
Okay.
Can you
Could you
order
log-
PT? Can you order?
He'll have
And
PT while
recommend-
he's here. If they recommend you doing more physical therapy when you go home, we can have either outpatient or sometimes they'll come by the house or,
So no rehab.
if physical therapy recommends him to go to rehab, then we can look at a rehab facility. If he's doing well enough that they don't recommend that, it's hard to get that approved. And I think you're gonna be doing well enough because you're young and healthy, and so I don't think you're gonna have problems with mobility. We can work on, like we said, to try to get a, lodging or something like that where home health can come out.
But like that feeding tube,
Mm-hmm.
you said like I'll be starting trying to swallow.
Yep,
Will
so
that feed
generally,
tube- will that feed tube come out before I come home?
no, that feeding tube will probably stay in for about 4 weeks, is probably about average. So usually that first month after surgery, you need it just for some supplemental feeds, because it's hard to get, and I wanna keep your nutrition up so that you're not losing tons of weight
Yeah.
in order to heal everything
Mhm.
and keep your energy up. So it may not be all of your nutrition that way. If you're eating well enough when you go home, then we'll just do a few cans of tube feeds at night, and then you'll be disconnected from the pump during the day.
And the cans of tube feeds are the Ensure
Those-
Boost
It's,
Or is that
generally
what
it's a
it
little bit
takes?
different. Those are ones that you would drink
orally.
orally, and you can certainly take those orally. The tube feeds that we run through the tube just are a little bit different. They're, just because they don't taste as good, and they're.
So those are ordered and then.
Those are ordered, delivered to wherever you want. The pump is delivered. Home health will help you with that. They'll teach you while you're here a little bit about the tube feed, cleaning it, flushing it, hooking you up to tube feeds, disconnecting. It's pretty simple. It's
Simple for somebody in the medical field, but we are not,
Yeah.
and it makes me all very nervous. Showering, bathing, all of those things, home health will
Yeah, you
assist
can
him
shower.
with.
You can shower normally. Certainly, if they had recommended that you have like a shower chair or something, if you get woozy, we'll provide that for you.
Think I will be woozy?
I don't think so.
Okay, based on.
I mean, but he is gonna have a rather big incision, and
Mhm.
you gotta be careful of that.
Yep,
When
we'll have
you-
an incision probably from about the breastbone down to the belly button.
What about tubes, drainage tube stuff?
You'll have at least one tube in, potentially 2 tubes. They're small, they're about the size of this straw or smaller. It's called a drain, and one sits up where everything is sewn together and where the spleen used to be around the pancreas. And I might put one underneath his skin just to prevent wound infections. Generally, both of those come out before you go home.
Oh, they will. So I'm thinking showering at home and dealing with those and dealing with the tube and the incision. I'm like,
Generally, soap and water can run over, the feeding tube can run over the incision when you go home. No soaking tub baths, but you'll be showering here before you go. I would recommend an epidural. I think we talked about that in clinic. It just helps numb up your incision. It can stay in for up to 7 days and just decreases how much narcotic you need, able to get you up out of bed sooner, moving around.
so that's just during hospitalization too.
Can only stay 7 days, that'll come out before he goes home.
Okay. So really at home, the only things we're concerned about is keeping the site, the incision site good,
Mm-hmm.
and keeping the feedings going through the J tube.
Correct. Yep, the incision should be mostly healed, for those first 10 days. And that's kind of the window that really the skin is really coming together and everything. So I won't have too much concern about the incision before you go home as far as any infection risk.
Now, we're still thinking that the tumor and the cancer within the tumor is localized.
Yep.
So you can kind of, once you remove it, make an assessment that we got it all.
Correct.
And the PET scan hopefully comes back clean on Friday with no
Yep.
spread indication.
Yep.
And so,
Potentially it would just be observation after surgery. If we don't see any evidence of disease, all the margins are negative, then we could talk about just observing, meaning getting a CAT scan in about 3 months after surgery and
routine
making
checks.
Routine checks.
Oh, that could be good, really really good.
It'll shorten your course, yeah.
Shorten the course.
As far as all of the treatment, because at first we were talking about some chemotherapy up front and then potentially the surgery. And so as far as the treatment course, if we're able to do everything surgically and we go into observation mode afterwards, I don't think there'd be an indication to give you more chemotherapy after surgery.
So all best case scenario, everything's removed, margins are clean. Do they say he's cancer free? Do they say he's in remission? Do they say he's, I mean,
Yeah. It would be going into our active surveillance, whether we call that remission is okay to say. I don't
okay.
use that term a whole lot, but you can say that.
I mean, for life, he's going to
But
have
yeah,
to
we would
monitored.
survey, yep. And they start to broaden the range, so we'd probably follow him for every 3 months, and then eventually we'll probably go to 4 and 6, and then yearly.
Okay, and life expectancy, if best case scenario, I mean, it could be, it's undetermined.
It's hard to know with these, it's hard to know. Yeah, sometimes these can, even if they ended up recurring, they can still be a lifelong type of disease that we
Manage.
manage, exactly.
So, but relatively healthy,
Yeah, no,
normal
overall, normal
existence.
working, yep. And I
People
can-
walking around aren't gonna know he's,
Correct. And I can, if you'd want, I can have some patients talk to you that have had similar types of tumor, if that's helpful.
I think that would be extremely helpful.
Okay. I'm seeing a patient in clinic today that have similar, hers started in the pancreas, which is more common, but similar.
But yeah, those stories I think would, help. Put a lot of anxiety and of the unknown aside a little bit. I mean, cancer obviously is a lot different now than it was, 30, 40 years ago. That's where my mind goes is, those early cases that, in my childhood that I heard about where the survival rate and everything was not so good. Now I'm like hearing cases left and right and people you would never know experienced anything like it,
Different cancers are different in what we have to offer. Neuroendocrine tends to have a very good prognosis. Okay.
Oh, that's great to hear.
Okay.
Alright.
I think this is the right path. I know you feel like we're kind of ping-ponging back and forth, but I think this is the right path.
Okay.
It's just unfortunate because I know.
Well, I know that you had started to arrange everything with your work too and everything, and now.
You think we'll stay safe for that 30th appointment?
If you're okay with it, we'll keep it. It's fine from my standpoint. If you need another week, we can push it back a week, but.
Yeah.
It's probably maybe this like the paperwork thing. Like how to give it, I think, Amanda.
Try and get that short term in
Oh, on our
in
end.
place.
Yeah.
Yep.
I think she
We can-
has it.
We
and,
can accelerate, if it's holding up on her end, I'll check.
Cause I think we were just holding off, just based
Right.
on the prior conversations regarding doing chemo and all that stuff.
Well, yeah, everything has been up in the air as far as a treatment regimen because of all of this.
We can maybe have Laura come by today. She's our care transitions nurse. She can help talk to you a little bit about what things look